Hello and welcome to the Bazooka. This is a series on my YouTube channel that is going to be focusing on preparing medical students for their OSCE exams. In each episode, we shall be looking at 10 important stations and one clinical course. And in this Bazooka episode, we shall be looking at internal medicine. My name is Dr. Moses Kazevu. If you still haven't yet subscribed to the channel, please subscribe to the channel. The majority of individuals haven't yet subscribed to the channel, and please drop a like, drop a comment, hit the bell icon to be receiving notifications for such videos whenever I upload. So this whole series is pretty much going to be focusing on different OSCE stations that are presented to you, and I shall present them in such a way that you could either get them as a physical OSCE exam or a projected exam. So I shall prepare you for either scenario or either case. So let's get into it. And please feel free to pause the video at any point so that you could actually try and answer the questions before I do, so that you can actually test how much you know and how much you get. So our station 1 is out of 10 marks. So the question reads, a 41-year-old male patient presents with chest pains. Take a history and ask important questions that will enable you to make a diagnosis. List the questions. Do not write an essay. And remember, each station is lasting roughly about 5 minutes, so you have to think very fast. So feel free to pause the video right now before I reveal the answer to you. I'll give you a 2-second interval. So whenever you're faced with such a situation, you always have to imagine that you're the person that's actually taking the history. And you don't want to take a history that is having so much details such that you lose track of whatever you're looking at. So in this case, you're faced with chest pain. So remember, whenever there is pain, you should think of Socrates. So if this is a physical OSCE station, please do not forget to introduce yourself, greet the patient, gain their consent, confirm that it is indeed the patient that you are talking to. So meaning demographics, the name of the patient, the age of the patient. I think it would be rude to ask about the gender. And at the end of it all, please do not forget to say thank you. But if it's a projected exam, then you could just start off straight into what you should ask. Remember, when you're assessing pain, we want to use Socrates as a mnemonic. So the S is for sight. Where is the pain? Is it central? Is it peripheral? Because all these things mean different things. If it's a peripheral type of pain, you're thinking it could be a lung pathology, it could be a pneumonia. If it's a central type of pain, it could be maybe that this person has esophageal reflux, maybe this person could have myocardial infarction. And of course, can you point to where you experience the pain? And then the O is for onset. When did the pain start? Is it sudden or gradual? Also, is it progressive or regressive? So these are also going to be pointing us towards the type of pain and the differential diagnosis that may arise. And of course, the character of the pain, how would you describe the pain? So some pains may be stabbing, like for example with pneumonias, you may get the stabbing pain, especially that's worsened with the deep respiratory movements, like for example when you're taking a deep breath. And is the pain constant or does it come and go? If it's constant, then most likely that this person may have been having a myocardial infarction. And then does the pain radiate? Remember, cardiac pain usually often radiates to the left arm, left jaw, sometimes even the right arm and the right jaw, and sometimes even the back. And then if it radiates to the back, or it radiates to the epigastrium, or it's found in the epigastrium and radiates to the back, all those things could mean different things on the differential diagnosis. And then the A is for associated features. So you ask if there are any signs or any symptoms that are associated with, for example, pain. Is there, associated with the chest pain rather, is there any cough? Is there any, if there's cough, is there any blood in the cough? Is there any weight loss? Is there any dizziness? Is there any shortness of breath? Is there any dyspnea? Is there any palpitations? These will, of course, give you an indication of whether the pathology is within the lungs or the pathology is within the heart. Then is there any fever? Is there any orthopnea? Is there any paroxysmal nocturnal dyspnea? So how I usually like to think of these questions is like, imagine like I'm taking a history of an actual patient. So whenever you're taking a history of an actual patient, always start off with your demographics. So in this case, they have already given you the demographics, so you do not want to mention that. Then you come to the presenting complaint, which is what we are talking about here. And of course, the time course of this, does the pain follow a certain pattern? Has it changed over time? Then we look at exacerbating or relieving factor. Does anything change the pain? Does anything make it worse? Like, for example, does exercise make it worse? Or does anything make it better? Does rest make it better? And then, of course, severity. How bad is the pain from 0 to 10? 0 being there's no pain at all, and then 10 being the worst pain that you've ever experienced. And of course, ask this person for a past medical history of HIV, because of course this could be an opportunistic infection that's affecting the chest. Ask for history of TB, or if they have any TB contact. Ask for history of pneumonia. Ask for history of asthma. Ask for history of any lung cancer that has been made prior. Then ask if they're taking any medication or they have any current allergies to any certain medications. Ask if there's a family history of asthma, because this could be asthma that they're having the chest pains. And on your social history, make sure that you ask if this person smokes. And if they smoke, ask for the duration and the number of cigarettes. And exactly what do they smoke? Is it tobacco? Is it cigarettes? Then the occupation is also very important, because this could be an occupation or lung disease. So please ask where they stay, or rather where they work, and if they're an outfield worker or they're a minor. So this could point you towards an occupational lung disease. So you should think of this very quickly in 5 minutes. So we move on to the next station, which is station 2. So here a 46-year-old presents with diarrhea, and get a relevant history and ask important questions that will enable you to make a diagnosis. List the questions, don't write the essay. Just like the previous station, if this station is a physical OSCE exam, please introduce yourself. Please gain consent from the patient, explain what you're about to do, then confirm the patient, the demographics of the patient, the name, the age, and preferably where they stay, because it's important to know where they stay, because the diarrhea could be an infectious diarrhea. For example, if someone is coming from a neighborhood that has poor sanitary conditions, a neighborhood that has poor water connection. So pretty much demographics, where they stay, then you come to your presenting complaint. So when did they first notice the diarrhea? When did the diarrhea first start? How long has the diarrhea been there? How many times have they had it in a day? So how often has it happened? And is there any blood or mucus in stool? Because this would point you towards dysentery. Is there any abdominal pain that is associated, or any nausea or vomiting that is associated? If there is vomiting that is there, what is the nature of the vomit? Is there any blood that is present in the vomit? When and where was their last meal? Because this could be food poisoning. And what was the last meal? Did they take anything that contained milk or any dairy products? Did they take a lot of sugar? Because this could be an osmotic diarrhea. And has the diarrhea gotten better with fasting? Have they fasted? And then is there any associated fever that may point you towards infectious conditions? Then you ask about the past medical history of HIV, because this could be an opportunistic GIT infection. You ask if they have any malabsorptive syndromes that were diagnosed. You ask if they have any history of any abdominal surgery. This could be tied in with the malabsorptive syndromes. Then, of course, ask for history of any medication that they're taking, because some drugs, some antibiotics could cause diarrhea. And then if they have any drug allergies, of course. Then a family history, if anyone else had the same meal or anyone else at home with the diarrhea. Then, of course, do not forget to ask about their source of water, and of course their toilet and the sanitation, because that is important when you talk about diarrhea. So keep this schema in mind, kind of like you're taking a normal history and there's a physical patient there. So how would you take that history to make sure that it's targeted towards the diarrhea? That's what they're getting you to learn. Next station is a very interesting station about an image. I always love the stations on images. So station 3, and each station is 10 marks. So identify the organism shown in the picture. So here's the organism, that's for 1 mark. What stain is used to identify the organism? That's another mark. Name the species that caused disease in man. How does man get the infection, and what organs can it affect? So that's about 4 marks. So I'll give you time again. Feel free to pause the video right now so that you can think through it. I'll give you a 2-minute or 2-second interval rather. Okay, so This is one of the conditions where it's rather a spot diagnosis. And if you have never seen this before, then you obviously will have no idea what you're looking at. So what you're looking at here is actually a stain that was done to identify Cryptococcus. So this is, of course, cryptococcal species. It's a fungi, of course. Yeah. So the stain that we usually use to identify Cryptococcus is known as India ink. So the stain obviously is India ink. And there are 3 important species, although this was reclassified. I think the reclassification is what I'm giving you. So there's Cryptococcus neoformans, that's the main species. Then it has variants, 3 variants. So there's a variant which is known as neoformans. So sometimes they may ask you this question alternatively, and they may ask you to talk about the variants of this condition, or the variants of this causative agent. So it could be Cryptococcus neoformans. It could be Cryptococcus neoformans variant grubi or grubi, however you pronounce it, or it could be Cryptococcus neoformans variant gatti. So those are the 3 important species that affect humans. And of course, how does a man get this infection? So usually a cryptococcal infection is usually gotten through inhalation of these encapsulated yeast spores. So usually most individuals that get the condition are those individuals that are immunosuppressed, and usually it starts off as a pulmonary infection and then disseminates to other parts, especially the CNS, depending on how low the CD4 count is in patients who have HIV. So which organs can it affect? So it can affect the lungs, so you call that as primary cryptococcosis. It could affect the brain in encephalitis. It could affect the spinal cord. It could even affect the meninges in meningitis, or both organs in meningoencephalitis. And then of course you could also have some multisystemic dissemination affecting the skin, affecting the prostate, and of course the medulla of the bone. Another additional segment that they could ask you for this, especially if you are a final year student, they may ask you about the treatment of cryptococcal meningitis. So remember that the drugs that we use to treat cryptococcal meningitis in our setting is a combination of a drug that's known as amphotericin B combined with a drug that's known as fluconazole. Now, how the treatment is done is usually it's done in 3 phases. So there's what is known as the induction phase, which usually lasts about 2 weeks, so about 14 days. Then in this induction phase, you're going to be, the drugs of choice that you're going to be giving are amphotericin B as well as fluconazole, or you could give 5-flucytosine. So you're going to be giving amphotericin B about 0.7 milligrams per kg as a slow infusion. You give this over 4 hours. You're also going to be adding fluconazole 800 milligrams orally daily up until 14 days. Then if you are using 5-flucytosine, you could give it at 100 milligrams per kg per day every 6 hours. Then the next phase is known as a consolidation phase, which usually happens for 8 to 10 weeks. So you're going to be giving your oral fluconazole about 400 to 800 milligrams per day for at least 8 to 10 weeks. And then the last phase is known as the maintenance, or you could call it as a secondary prophylaxis. So usually we give these people only fluconazole, about 200 milligrams per day. Some people recommend that you actually give this as lifelong, but recently there were some physicians that recommended that only give this up until their CD4 count has been greater than 200 cells for the past 6 months. And then another possible question that you may be asked if you're a final year student is, of course, the side effects of the drugs that you just mentioned, especially with amphotericin B. Remember that amphotericin B causes renal dysfunction. It has electrolyte imbalances such as hypokalemia, hypomagnesemia. It also is hepatotoxic. Remember, antifungals are hepatotoxic. So you're going to have abnormal liver disorders. Sometimes it may lead to thrombocytopenia. Sometimes it may lead to anemia. Sometimes it may even cause arrhythmias. So those are the possible stations or the possible questions you could be asked on the station, especially for final year students. Moving on to the next station, so station 4. Whilst working, you make a diagnosis of meningitis in a patient. You decide that the patient needs a lumbar puncture. Question 1, describe how you go about it. Then part 2, name the layers of the needle you would pass through to reach the CSF. Again, here I shall give you a 2-second interval for you to pause the video and give your answers. You could be writing this on a piece of paper. I don't know why you're screaming at your screen right now, but anyways. So whenever you're doing a lumbar puncture, you should always remember that every procedure that is done in the hospital must be done with consent. And a lumbar puncture is a sterile procedure, so ensure that there is sterility to this procedure. So the first thing that you're going to be doing is, of course, introducing yourself. Get signed and written consent. Make sure that you explain the procedure to the patient. Explain why you are doing the procedure, why this patient needs this procedure, and explain what are the benefits of them getting this procedure. Like, for example, you'll be able to make a diagnosis and know which drugs they could be that could be used to treat the condition that they have, in this case meningitis. Because what most people have is this notion that if they get a lumbar puncture, they're most likely going to die. So your job or your role is to actually explain that the lumbar puncture is not actually going to kill the patient. It's the underlying disease that's most likely going to kill the patient. Then, of course, after you've gotten consent and introduced yourself and everything, please make sure you prepare adequate equipment. So you're going to be needing your sterile dressing, which could be sterile gauze, some strapping. It could be those blood collection bottles. You'll need about 3 of them. Then, which I should be the red top bottles, the ones which do not have anything in them. Then, of course, you need some methylated spirit. You need also some iodine solution, and of course some sterile gloves. So please make sure that you prepare this equipment. Wash your hands. And of course, position the patient. So you'd wash your hands and don the sterile gloves. So you position your patient in the left lateral decubitus position, and you could either position them upright, seated, or whichever position you want to put this patient. And of course, in both these positions, ensure that the spine is straight and it's flexed as possible. So tell them to take their knees and bend their forehead towards their knees. So kind of like the fetal position. Then, of course, you should identify the site. So usually the landmarks that we look at is the posterior superior iliac spines. So you draw a line between those posterior superior iliac spine, and then you go in the vertebral, you feel for the vertebral processes, and then the space just above this line, the most open space, that's where you go in with your needle. And so you mark your iliac crest and the vertebral space located at the same level, which is L4, L5. You palpate L3, L4, L4, L5, L5, S1, and then of course mark the interspace which is most open. And then of course sterilize the puncture wound with iodine solution and methylated spirit, and using a spinal needle or a 20G needle, and donning your sterile gloves. You should enter the middle of the space, and of course you're going to be advancing the needle in a perpendicular manner. So it means it should be parallel to the ground, and it should be towards the umbilicus. And of course you'll feel some resistance until there's a giving, and then when the giving happens, that's when you're passing through the ligamentum flavum. And then of course CSF, once CSF starts flowing through this needle, you could measure the opening pressure based on the flow rate, and of course collect fluid in at least 3 separate bottles. So one bottle, you're going to be placing the CSF, you place a urine dipstick and actually record the results. The second bottle, I would want you to collect 1 to 2 mils of CSF and send it to biochemistry, where they're going to be analyzing the total protein and glucose. The second, or the third bottle rather, is going to be sent to, or the second bottle rather, the second bottle is going to be sent to microbiology for a gram stain. It will be about 5 mils, gram stain, microscopy, culture, and sensitivity, where they'll use different stains on it. One of it being, of course, this modified Ziehl-Neelsen stain for TB. Then, of course, the third thing is going to be going to hematology, where they can look at the cell counts as well as the differential count. And after you've collected all your samples, please remove the needle from the patient, cover the area and with sterile strapping, or sterile gauze rather, or sterile dressing, and ensure that there's no leakage and there's no blood. And of course, thank the patient after you finish the procedure. So the other part of this question was, what are the layers? So you first go through the skin, then you go to the subcutaneous tissue, then you go to the supraspinous ligament, then you go through the interspinous ligaments, then you go through the ligamentum flavum, then you go to the epidural space, and of course inside this epidural space you have the internal vertebral venous plexus, then eventually you go to the dura, then the arachnoid, and then finally you're in the subarachnoid space, which is where the CSF is going to be flowing. An additional question that you may actually be asked on this station as a final year student would be, they may give you a result of CSF analysis, so please take note of how to analyze a CSF study. I shall release a video very soon. What is soon? I shall receive a video very soon, or release a video very soon rather. I don't know what's happening to my English. I shall release a video very soon about meningitis, so please stay tuned to that. And if you're enjoying these videos, please drop a comment, subscribe to the channel, and show some support. Now in the next station, which is another image which looks really interesting. So station 5, you have 2 images here. So mention at least 2 abnormalities in this image. What is the diagnosis? Mention 1 CNS, 1 peripheral nervous system manifestation of this condition. Mention 1 hematological manifestation of this condition. List 2 cardiovascular manifestations of this condition. List 2 manifestations of, or 2 lung manifestations of this condition. Again, I shall give you some time to actually think through this question, and you may even pause it at this moment. But don't pause it for too long, yeah? Remember, these stations are only for 5 minutes. Okay, so what you're seeing here is this person here. As you can see, there's the digits are bending towards the ulnar aspect in this area here, as you can see here. So you refer to that as ulnar deviation. And then in this bottom image over here, as you can see, what has been circled here, this looks like a swan's neck. So you have this flexion that is happening at the distal interphalangeal joint, so you refer to this as a swan neck deformity. And then of course, once you have this flexion at the proximal interphalangeal joint, and you refer to this as a Boutonniere's deformity. So you have ulnar deviation, you have a swan neck deformity, and you also have a Boutonniere's deformity. And you see these things, of course, in rheumatoid arthritis. So mention 1 CNS and 1 peripheral nervous system manifestation of this condition. So in the CNS, you could actually have the spinal cord compression, especially if there's an atlantoaxial subluxation, which is pretty much like a dislocation of this joint between the atlas and the axis. Then you also so you refer to that as a cervical myelopathy or radiculopathy. Then you may also have some nerves that are actually being entrapped in tunnels, like for example carpal tunnel syndrome, where you have a nerve being entrapped, especially at the wrist. Then question number 4, mention 1 hematological manifestation of this condition. So you could either have anemia of chronic disease, or you could have thrombocytopenia. List 2 cardiovascular manifestation of this condition. You could have pericardial effusion, you could have atherosclerosis, you could have rheumatoid vasculitis, you could have myocarditis, you could even have some valvular dysfunction, which is most likely mitral regurgitation. So you could just pick any 2 from here. Then list 2 manifestations of this condition: interstitial pulmonary fibrosis, you could have pleurisy, you could have pleural effusions, you could have obliterative bronchiolitis. So some other additional information that you may be asked here as a final year student is sometimes they may ask you, what is Felty syndrome? So remember that Felty syndrome is actually a syndrome that's going to be consisting of a chronic rheumatoid arthritis, and of course you're going to be having number 1, splenomegaly, number 2, there's going to be neutropenia, number 3, they may sometimes be thrombocytopenia, and there may be anemia. So sometimes they may ask you what Felty syndrome is, so please be aware of that. And remember, rheumatoid arthritis can sometimes be part of a multisystemic condition which may affect many systems. So there are different systems on different organs, so or different manifestations on different systems. So make it your task to actually research about that and actually look up the different manifestations associated with rheumatoid arthritis in the different organs, because they're not just limited to these systems that they have asked you. Sometimes there could be some dermatological manifestations such as Sjogren's syndrome, such as Raynaud's phenomenon. Sometimes you could even have these rheumatoid nodules. There could be even some genitourinary manifestations such as an amyloidosis, even some glomerulonephritis. Then you may also get some neurological manifestations, like for example in the eye. If you consider that as part of the neurological system, you could have keratoconjunctivitis sicca, which is also part of Sjogren's syndrome. Then you could sometimes even have scleritis. Then station number 6 is a female that's 25 years in the picture, presents to the emergency room with raised blood pressure. So what features are of note in this picture? There's 3 marks. What other features would you elicit in such a patient? That's again 3 marks. What is your diagnosis? What are the possible causes of your diagnosis? So take a look at this picture and absorb this picture. Again, you could pause the video at this moment so that you could answer the question. So I shall give you the answer now. So this woman here, as you can see, she has this round, large face here, which is referred to as this moon face. As you can see, there is some acne that you can see on her face, and of course you could see this hair distribution looks like as if it's of a male pattern, so you call that as hirsutism. Then of course you could see the redness of the cheek, or the plethora, that you could see here. So that's what we're seeing. So this is a typical feature of Cushing's syndrome. So what other clinical features would you elicit in this patient? So you would have progressive central obesity. So usually these patients have the central obesity and they have very thin proximal limbs. So they may have this proximal muscle weakness. They may have weakness of the lower limbs. Like for example, they are not going to be able to squat and then get up. They have difficulties in climbing stairs. So they may also have this purple abdominal striae, which are just purple stretch marks on the abdomen. They may have easy bruising of the skin and skin atrophy. They may sometimes have this buffalo hump, or you call that a cervical fat pad, which may present as a kyphosis or a hunched back. You may sometimes have a supraclavicular fat pad. Then this should be pad, not pads. In this case, given that it's a female, there may be oligomenorrhea or amenorrhea. There may be some poor wound healing. There may be proximal muscle weakness, like I already told you. There may be polyuria or polydipsia. So your diagnosis, most likely, because this patient came in with a raised blood pressure, so hypertension that is secondary to Cushing's syndrome. Remember the difference between Cushing's syndrome and Cushing's disease? The difference is in Cushing's syndrome, the ACTH is coming from different places other than the pituitary gland. If the rise in ACTH is coming from the pituitary gland, then you refer to that as Cushing's disease. And what are the possible causes? So they could be ACT dependent, so things like a pituitary adenoma. You could have ectopic ACTH producing tumors such as small cell lung carcinoma. These tumors are very notorious for producing hormones that they're not supposed to be producing, so it could be part of a paraneoplastic syndrome. And of course, this person could be having exogenously administered ACTH, or indeed it could be a non-ACTH dependent a cause, like for example in adrenal adenomas or carcinomas. You could have adrenal hyperplasia or even exogenous administration of glucocorticoids. The next station here is another interesting station. So station 7 is a chest x-ray. So what is shown in the chest x-ray? Give 2 main differentials, list 3 causes each for the above 2 differentials. So again, feel free to pause the video and take your time to answer this, but not too much time. Ensure that you answer everything in 5 minutes. And please, as you have seen, there's pretty much a lot of thinking that has to go on the spot and a lot of writing. So if you have a preset template in your mind, it makes it very easy to answer these questions on your OSCE exams. And they may not necessarily ask you the exact same question, but if you train your mind to think fast or to think in a certain way, it makes it very easy to answer these questions, and you could actually maximize and actually come out of that exam room having written a lot more than your colleagues after you have watched these videos and you've gotten used to these series of videos that I'm releasing. So here comes the answer. So this was an x-ray of a 9-month-old child who had a severely dilated cardiomyopathy. I don't know how it showed up on an internal medicine exam, but anyways, pediatrics is also a branch of internal medicine. So what we can see from this is you have this broadened spatulate ribs that you can see over there, broadened spatulate ribs, and then of course the cardiothoracic ratio is increased, so there's cardiomegaly here. So the two main causes, of course, your diagnosis here was a severe dilated cardiomyopathy or DCM, and then of course your differential diagnosis would be a valvular heart disease, most likely a mitral regurgitation, but this is more likely. Then list three causes for the above two differentials. So with severe DCM, it could be a vitamin B1 deficiency or thiamine, you refer to that as beriberi. You could have infections such as Kawasaki's, Chagas disease, which is due to trypanosoma cruzi. You could have HIV infections. You could have some drugs such as doxorubicin, which is famous for causing dilated cardiomyopathies. You could have hemochromatosis, where there is an excessive iron deposition in the myocardium. You could have alcohol, which is not so common in children, but if it's in an adult, it could be very common. And then, of course, pregnancy, which is also not so common in children, but much more common in adults. And then if it's a valvular heart disease, it could be rheumatic heart disease or indeed infective endocarditis. So station 8, you have a male that's 57. This is a known diabetic and hypertensive for 6 years, unknown HIV status, developed abdominal fullness, but no pain a month ago, developed leg swelling, both legs 2 months ago, and noticed the face was puffy in the morning. Urine is frothy. He has associated gradual increasing shortness of breath with no chest pains. He developed spontaneous bruising over the past 5 months. So that's a mouthful question. So what is the likely diagnosis? What investigations will you do? And give the findings you would expect for each test. And then, of course, list possible causes. So pause the video again, but here comes the background. So you get a patient who doesn't have their HIV status, and of course they have diabetes and hypertension, so all these are risk factors. And of course they develop this ascites and of course swelling of the leg, so most likely it's generalized, and in the morning it's puffy. So whenever you see puffiness in the morning, it should ring a bell in your mind that the problem is in the kidneys. So you get this frothy urine. This obviously could be due to some proteins in the urine, and of course the gradual shortness of breath is, you could understand, because there may be some fluid that's also accumulating in the lungs, and because there's no chest pains, you should forget about some infections. And of course this spontaneous bruising, it could mean that you're losing a protein that is very important in actually causing blood clotting disorders. So most likely this patient here has a nephrotic syndrome. So let's look at the answers. So this patient has a nephrotic syndrome in a known diabetic and hypertensive patient. That's your most likely diagnosis. What investigations may you do? So most people here would jump straight to be answering and say a 24-hour urine collection. So this is not actually quite specific, and there are much more specific tests. You may do a urine albumin creatinine ratio, which is the most specific of these three tests. If you get a concentration that's greater than 250 milligrams per millimole, then you make a diagnosis of nephrotic syndrome. You may do a urine protein creatinine ratio. If it's greater than 300 milligrams per millimole, you make your diagnosis of nephrotic syndrome. And of course, you could do your 24-hour urine collection test where you get greater than 3.5 grams per day. You may also order for serum albumin, and of course it will be decreased because you're losing the proteins in the urine. You may order for serum cholesterol, you may order for triglycerides, you may order for LDLs, which will all be increased, and of course the HDLs, the high density lipoproteins, will be normal or reduced. Remember, these are the good lipids, these are the bad lipids. You may also want to do a renal ultrasound or pelvic imaging to of course rule out any pathologies of the kidneys, because sometimes they may shrink or they may be enlarged in case of a polycystic kidney. And of course definitive diagnosis would be your renal biopsy, where you may actually determine the type. It could be focal segmental glomerular sclerosis, it could be minimal change disease, it could be membranous nephropathy, and membranous proliferative disease. Then, of course, list 3 possible causes. So, of course, in this case, it could be due to hypertension, hypertensive nephropathy. It could be due to diabetes, diabetic nephropathy. It could be due to some autoimmune conditions. But before I mention this, it could be due to infections because this person had HIV whose status was unknown. So, it could be HIV. You could have autoimmune conditions such as SLE, vasculitis. You could have some infiltrative conditions such as amyloidosis, where you deposit these amyloid proteins, or even sarcoidosis. You could have some collagen vascular diseases and other infections such as malaria, hepatitis B virus, hepatitis C virus, Epstein-Barr virus, leprosy, and syphilis. Remember, on your OSCE exams, please do not write in abbreviations, always write everything in full. Then you could also have some drugs. You could have some tumors such as leukemias, lymphomas, as well as solid tumors, all causing nephrotic syndrome. Remember that nephrotic syndrome could either be primary, meaning it's idiopathic, or secondary, meaning it's secondary to something. Station 9 is a blood slide. We're almost towards the end, so if you still haven't subscribed, please hit that subscribe button and drop some likes on this video. So station 9, so this is a peripheral blood smear of a 30-year-old female who's admitted with severe decompensated anemia for blood transfusion. So of late, she has developed a very strong craving for ice, so you refer to this as pica. Her hemoglobin is 3.6 grams per deciliter. What is the diagnosis? List 5 possible causes, list 5 abnormalities on the peripheral blood smear, list 5 other investigations you may request. So the investigations that have already been done are the peripheral smear and a full blood count. So you don't want to see students answering and saying full blood count on this station and then you expect to get marks. So that would be impossible. So this woman here has a microcytic hypochromic type of anemia. How do I know this? Of course, usually these cells are much smaller than the nucleus of this lymphocyte. So as we can see, these cells are small and they are less pink than usual. So this is a microcytic hypochromic anemia. List 5 possible causes. So iron deficiency is the most likely cause in this case. So it could be due to malnutrition, it could be due to malabsorption, it could be due to chronic blood loss. Conditions such as peptic ulcer disease. You could have hookworm infestations with 2 important hookworms, Ankylostoma duodenale as well as Necata americanus. You may also have hemorrhoids or piles. And then you may also have anemia of chronic disease or thalassemias, though thalassemia is not so common. Then list 5 abnormalities on the peripheral smear. Of course, as we can see, these small cells, which are referred to as microcytes. We can see that there are different sizes of these red blood cells on the slide, so you refer to that as anisocytosis. There are, of course, different shapes on this red blood slide. You refer to that as poikilocytosis. As we can see, there are some cells that have this pale ring that's surrounded by this red thing. Here, you refer to these as codocytes or target cells. Then, of course, there are these cells which kind of look like it's a helmet like this. So you refer to this as helmet cells. Okay, so those are the 5 abnormalities that we see on this slide. So what 5 other investigations may you order for? You may order some iron studies where you look at serum iron, total iron binding capacity, which is simply measuring the transferrin, then percentage saturation, how many molecules of transferrin are bound, and then of course looking at the serum ferritin, which is the storage form. You may take some stool for occult blood in case this person has a bleed. You may take stool for ovine parasites in the case of Ankylostoma duodenale and Necata americanus. You may do some pelvic gynecological studies in view of this woman being a female. And then they could be bleeding, it could be fibroids. And then, of course, do an upper and a lower GI endoscopic studies to see if there's any peptic ulcer disease or any tumors in the GIT. So the last and final station, which is also a blood slide. So this is a peripheral smear from a patient who has just been admitted to an emergency ward with severe generalized pains. This is the 4th admission in the last 12 months. So this must be a recurrent thing or a chronic thing or a thing that's been there for quite some time. So what is the diagnosis? What is the molecular basis of this condition? List 5 triggers of the patient's generalized body pain. List 3 other clinical manifestations of this condition. So if we look at this blood slide here, what's very, very important is you get these sickle-shaped red blood cells here. As you can see, we also have these target cells over here, or codocytes. So obviously, this is sickle cell anemia. Then, of course, what's the molecular basis of this? So this is an autosomal recessive inheritance, meaning that for one to actually have the disease, they should inherit both recessive genes from both parents. And of course, the underlying pathology is that there's a point mutation in chromosome 11, where there's a substitution of adenine to thymine. And of course, this is going to be resulting in a substitution of valine for glutamic acid. This is substitution of supposed to be the other way around. So glutamic acid is replaced by valine, and of course at the 6th position of the beta chain. So it means that valine, which is now there, is hydrophobic, so it will change the shape of hemoglobin. Then list 5 triggers of the patient's generalized body pains. So you have hypoxia, dehydration, cold, acidosis, infection, even living in high altitude. So all these could be triggers, especially if someone has sickle cell trait. So remember also the differences between sickle cell disease, sickle cell anemia, as well as sickle cell trait. If you still do not know this, stay tuned. Also, I shall be releasing another video on sickle cell. So please subscribe to the channel and hit the bell icon to receive notifications every time I post, so that you do not miss any single thing when I post these videos. Then list 3 other clinical manifestations of this condition. So I thought I'd end this off with an image. So here is a head-to-toe manifestations of sickle cell. So you could have cerebral infarcts leading to stroke that would lead to mental retardation. You may have retinopathy, so you may have retinal hemorrhages, so the person may actually go blind. In the cardiovascular system, you may have congestive heart failure. In the lungs, you may have pulmonary infarcts leading to pneumonia. You may sometimes even have an acute chest syndrome. Then in the GIT or the abdomen, you may have cholelithiasis, which is of course the gallstones. You may have splenomegaly and eventually splenic atrophy, which is autosplenectomy, and this will predispose someone to recurrent infections, especially with encapsulated organisms. Then of course you're going to have some renal infarcts, which may lead to hematuria. You may sometimes have infarcts in the extremities, of course, which is what the patient was presenting with, your vaso-occlusive crisis. You may sometimes have bone marrow hyperplasia. Sometimes you may have aplastic anemia. Then of course you may have aseptic bone necrosis, which may lead to osteomyelitis. You may sometimes have these leg ulcers in this patient. So remember all these clinical features on sickle cell anemia. Stay tuned to the video. Stay tuned for the video that I shall release on sickle cell anemia. And this is indeed the end of episode 1 of the Bazooka. If you enjoyed this video and you want more of such videos, please share the videos, drop a comment, subscribe to the channel, hit the bell icon to be receiving notifications every time I post, and stay tuned for episode 2. If you haven't subscribed, subscribe, share, comment, and like. Until next time, bye bye.